Living in Toronto, Ontario, Alyssa Lola Garcia, a 75-year-old postmenopausal Filipino female, was admitted to the ER after falling over her newly mopped kitchen floor.
Oh no, my Lola, she's broken.
Her grandson found her in severe pain, of which she reported was an excruciating 8 out of 10. Lola had an x-ray taken of her left hip area, which indicated a hip fracture. However, the radiologist had more to reveal and was afraid to break further news to her. But before we look at the radiology report, let's go over the life of Lola. Lola's the life of the party. Sometimes you'll find her drinking with her bingo friends during Tuesday and Thursday nights. She used to smoke too, but recently decided to quit years ago. Currently weighing at 105 pounds at 5'4", Lola begins to accept that her body is slowly getting weak and fragile. How are you feeling, Lola Alyssa? Any signs and symptoms that's been bothering you lately?
There's a lot that has been bothering me. For the past few days, I've noticed that my fingernails have been getting brittle. And my gums too. They've been hurting so much that I've had to switch to using an even softer toothbrush. But if anything, my back has been aching a whole lot along with my hips. It is tough for me to get up the stairs. I've been running out of breath quickly, and not just the stairs, I've been out of breath even while walking around the house. And oh my grandson thinks I got a bit shorter, and we actually measured my height the other day, and it turns out I actually lost 3 inches. How is that possible?
And what about you? As a grandson, how do you feel about your Lola?
I'm scared for my Lola. She couldn't get up from that fall at all. She used to weigh a healthy 120 pounds, but now you can see that she has lost a lot of weight. I know she has a history of hypertension, rheumatoid arthritis, and GERD. She always stays at home with me and rarely goes outside. She doesn't like exercising too because she says her body aches and would rather choose to sit in her rocking chair all day long. As for her diet, I think she eats okay. She's just not a fan of dairy at all. She doesn't like the taste of milk.
I already go through so much pain, and now this? A hip fracture? Is there more that I should know about?
Here we have your x-ray scan. First, let's take a look at your bone mineral density. This is essentially a measurement of how compact your bones are. We use a tool known as DEXA, or dual energy x-ray absorptiometry. If you remember, we took a DEXA test on you when you were admitted after your fall. In the procedure, you're relying on an examination table, and an x-ray detector scans the bone region on your body. The amount of x-rays that pass through the bone are measured and displayed as an image which was interpreted by me, your radiologist. The test causes no discomfort, involves no injections or preparations, and usually takes around 5 to 10 minutes to complete. After the test, the doctor looks at the results, and you will be given a score that speaks to the conditions of your bones.
And do you have my results?
Hi Lola, my name is Dr. Suss. I have your DEXA results here on hand. The results are presented as T-scores, whereas a score above -1 is considered normal, while a score between -1 and 2.5 is classified as osteopenia, the first stage of bone loss. And a score below -2.5 is indicative of osteoporosis. Essentially, the lower the bone density, the lower the T-score, which is the greater the risk of fracture. Based on the findings, you have a score of -1.6 on your lumbar spine and a -2.1 on your left femoral neck. Since you are of advanced age and postmenopausal, you are at higher risk and you have osteoporosis, Lola.
So you might be wondering, what exactly is osteoporosis? Osteoporosis is a disorder of bone remodeling resulting in weak, fragile, and porous bones, particularly observed in postmenopausal women and with progression of age. Many of the drug categories like bisphosphonates, serums, vitamin D preparations, biologicals, parathyroid hormone analogs, calcitonin, and calcium supplements are indicated for osteoporosis.
Let's first break down what osteoporosis is. What is osteoporosis? Osteoporosis is caused by an imbalance in bone remodeling, which results in reduced bone formation and increased bone resorption. As bone strength is decreased, we can observe it become more weak. They become more brittle, and pain is also associated.
What are the causes for osteoporosis? Osteoporosis is actually observed both in men as well as in women, but particularly more observed in women because of hormonal effects, as well as the loss of this calcium from bones due to menopause. In postmenopausal women, there is a lack of estrogen synthesis, which results in decreased bone strength and demineralization of the bones. Osteoporosis can also be observed with the progression of age both in men and women. There is a gradual loss of bone mass because of the demineralization as well as the increased osteoclast activity.
Osteoporosis can be observed with glucocorticosteroids such as prednisone, antagonists like tamoxifen, which is used for treatment of breast cancer, and acids used for GERD, proton pump inhibitors PPIs, which can produce weakening of the bones, as well as heparin, an anticoagulant.
Pop quiz, question number 1.
So the correct answer for is A. Low levels of estrogen during menopause lead to increased bone resorption. So due to low levels of estrogen during menopause, estrogen deficiency causes the normal bone turnover cycle to be impaired. This means that the osteoclastic resorption activity increases while the osteoblastic activity decreases. As a result, the amount of bone resorbed exceeds the amount deposited, which leads to a net loss of bone. The increase of overall bone resorption is due to a weakened inhibition effect due to the reduction of available estrogen on both osteoclastogenesis and osteoclast activity. It is also important to note that there are two phases of bone loss in women. The first occurs predominantly in trabecular bone and starts right after menopause. It results from estrogen deficiency and leads to a disproportionate increase in bone resorption and decrease in bone formation. This phase could be defined as menopause-related bone loss, and around 4 to 8 years afterwards, the second phase exhibits a persistent, slower loss of both trabecular and cortical bone and is mainly attributed to reduced bone formation. Overall, during the menopausal transition period, the average reduction in BMD or bone mineral density is around 10%. Approximately half of women are losing bone even more rapidly, perhaps as much as 20% in those 5 to 6 years around menopause.
Now let's go back to the clinic.
Hi Lola, we just got your results back for your comprehensive metabolic panel, your complete blood count, and your 25-hydroxy vitamin D test. First of all, vitamin D levels between 20 to 50 ng per milliliter are considered adequate for healthy people. On your charts, it seems as if your vitamin D levels measure at 10 ng per milliliter, which unfortunately indicates vitamin D deficiency. So what is most important to know is that vitamin D and osteoporosis come in hand. Vitamin D is initially inactive in your body, and it is converted to its active form in the kidneys. This is known as calcitriol, a hormone which acts on vitamin D receptors to increase both intestinal and renal calcium uptake. This uptake is used for bone mineralization, and essentially vitamin D absorbs calcium for use. Hence, low levels of each greatly increases your risk and severity of osteoporosis. As for your CMP and CBC, all those labs were within defined limits. With the exception of calcium, Lola, unfortunately your calcium levels are very low. The normal ranges for calcium is 2.18 to 2.58 millimoles per liter, and you happen to have at a staggering 1.81. Calcium has a major role in bone mineralization, and this involves the gradual deposit and development of new bone, which is a process occurring throughout the lifespan. With an insufficiency in calcium, you may be unable to build strong, healthy bones, increasing your risk of falls and fractures. But don't worry, I'll give you some calcium supplements to compensate for your hypocalcemia, as well as cholecalciferol for your vitamin D deficiency.
Speaking of, what medications will I be taking?
So before the physician lists her new medications for osteoporosis, let's take a look at her current medications for her other coexisting conditions. This ensures we're aware of any drug interactions or contraindications for our patient Lola. So how do drugs act in osteoporosis? So bone remodeling is an important process involving osteoclasts and osteoblasts. In a nutshell, osteoclast is for bone resorption, whereas osteoblasts is for bone formation. Our target goal for Lola is to inhibit her osteoclast formation and or promote osteoblast formation. So the drugs she is going to receive mainly act by inhibition of the former and promotion of the latter.
for Lola's hypertension, it looks like she's been taking the following: benazepril, amlodipine, and a loop diuretic, furosemide. Next, for GERD, she has a proton pump inhibitor, pantoprazole, as well as an antacid, aluminum hydroxide. And lastly, to help with her rheumatoid arthritis, she's been taking aspirin. And from her current medications, we can see that polypharmacy is present. The following drugs may have interactions and an interference with osteoporosis and its signs and symptoms.
Pop quiz again. Question number 2. You're right. So the answer is B. So we should discontinue her proton pump inhibitor pantoprazole because these PPIs are well known to increase fracture incidences as their mechanism of action works by inhibiting calcium absorption. PPI is effective in treating Lola's GERD. However, with her new diagnosis of osteoporosis, it only results in an increase of fracture risks. As an alternative, we can probably think that Lola should instead use an H2 antagonist as prescription of PPIs for her GERD treatment, because PPIs should at least be avoided with patients diagnosed in osteoporosis. So now let's see what the different types of drugs Lola will be taking used in the treatment of her osteoporosis.
The first one is bisphosphonates. The structure looks like this, and we can observe the 2 phosphate groups here at the terminal ends. These drugs enhance bone mineral density by preventing bone resorption caused by osteoclasts. Osteoclasts are in charge of breaking down bone, which then allows more calcium to be reabsorbed into the bloodstream. The drugs Lola will be taking under this class are Fosamax and Actonil, both 5 mg per day by mouth.
Then we have raloxifene. Raloxifene is an SERM or SERM, and it acts as a partial agonist by stimulating agonist activity of estrogen and exerts an anti-resorptive effect on bone tissues. Raloxifene helps increase osteoblasts. SERMs, as indicated by their name, mimic the action of estrogen. Raloxifene in particular stimulates estrogen receptors to increase bone density. It is highly effective for postmenopausal osteoporosis. Lola will be receiving a dose of 16 mg per day by mouth.
The third drug will be teriparatide, and this is a parathyroid hormone analog. This is responsible for osteoblast activity, which leads to bone formation. However, teriparatide does not have any anti-resorptive effects. Parathyroid hormone receptor agonists act by stimulating bone formation. It is a derivative of parathyroid hormone and acts to treat osteoporosis by regulating the body's metabolism of calcium and phosphorus. 80 micrograms of abaloparatide and teriparatide will be administered daily. Supplemental calcium and vitamin D can be added if dietary intake is inadequate.
The fourth drug will be the biologicals, one of them being denosumab. This is a human monoclonal antibody for the treatment of osteoporosis. Osteoclast promoter cells have receptors called rank receptors, of which rank ligands bind to, and they go through modifications to stimulate proliferation and differentiation of cells, ultimately resulting in bone resorption. Denosumab works by antagonizing the binding of this rank ligand to this receptor, thereby inhibiting the conversion of the osteoclast progenitor cells to the multinucleated osteoclast cells. In this way, denosumab inhibits bone resorption. Administration of romosozumab in 2 105 mg injections, total of 210 mg, once a month for 12 months will help increase bone mass and strength. Supplemental calcium and vitamin D can also be added.
The fifth drug is calcitonin. Calcitonin is a peptide that has 32 amino acids and is secreted from the thyroid follicles. The main acuity of calcitonin is to decrease bone resorption, as well as calcium and phosphate reabsorption into the renal tubules. Calcitonin is one of the drugs that can be given intranasally and can also be used to relieve pain. As previously mentioned, calcitonin is the active form of vitamin D, and it is involved in the absorption of calcium. 100 units of miacalcin will be injected intramuscularly every day.
The sixth one would be vitamin D preparations. These drugs are like ergocalciferol, alpha-calcidyl, and calcicitriol. These are mainly responsible for increasing calcium intestinal absorption, as well as decreased calcium excretion.
And last of all, we have other preparations such as strontium, which increases bone formation and decreases bone resorption. Similarly, we have calcium gluconate, which is indicated for hyperkalemia and can act as a calcium supplement for those with osteoporosis. Pop quiz question number 3.
You're correct. It's B. The nurse should perform the teach-back method with Lola to assess her understanding of her prescribed drug regimen. Medication adherence is most commonly a concern for older clients. Nurse-led interventions such as home visits, verbal advice, fact sheets, care plans, and written reminders either by phone or electronically were shown to improve adherence. The nurse should create a medication schedule that suits Lola best. In the morning, afternoon, and nighttime are most memorable and convenient. For teach-back method, have Lola restate the name, general mechanism, route, dosage, and frequency of her prescribed medications. Medication reconciliations can be done prior to discharge.
Now we're going to listen to a man named Gary who speaks about his life with osteoporosis.
I'm Jerry Corcoran. I live in Toronto, Canada. In 2008, I was diagnosed with osteoporosis. My doctor thought it would be a good idea to send me for tests because my mother had had a fracture, and he was concerned that this sort of thing ran in the family. So he was right. Now, he put me on medication, and he told me to increase my vitamin intake and my calcium intake. So I did that for several years. A few years ago, I went for a routine physical, and the doctor told me that my vitamin D levels were low. As a result, my medication wasn't being absorbed properly. So he told me to increase my vitamin D levels. I went up to 4,000 international units. After about a month of that, the doctor called me into his office and he told me that I no longer had osteoporosis, but osteopenia. Now that's a positive development, really, to have osteopenia rather than osteoporosis. I'm not worried about osteoporosis or osteopenia. Some people are, but I know there are risks of fractures, so I'm conscious of that. I don't think that having osteoporosis has changed my life all that much. I am conscious that I need to exercise and I need to take long walks because weight-bearing exercise is very helpful, very beneficial for people with osteoporosis. Now, when I go to the osteoporosis office, I walk there. It's about an hour and a half walk, almost 4 miles. It gives me a bit of a cardio workout, gives me some weight-bearing exercise, and saves me a transit token. So it hasn't changed my life all that much. That's what I find. I know that some people are frightened of it, some people are scared that they may have a fracture. A few weeks ago I was on my way to the office and the sidewalk was kind of uneven, so I tripped. I fell flat on my face, cut myself a bit, and I thought, oh no, I've done it this time. I've given myself a fracture. But I dusted myself off. I was fine. I'm conscious of what I eat now. I'm conscious of foods that are rich in calcium or vitamin D. In the old days, I used to throw out that little column of bones in a can of salmon. Now I grind it up into the salmon. I know I should eat more leafy vegetables. I should eat more broccoli and kale. I like broccoli, but I'm not that fond of kale. I retired in May of 2010, and I thought I would call the Osteoporosis Canada and offer to do some volunteer work for them. So they accepted me. Tanya Long was the National Education Manager. She encouraged me to come in and have an interview with her. And I do a little bit of volunteer work, such as answering the phones, speaking to people, counseling them. I'll send out information packages. Sometimes I work on processing the receipts that come in from the various donations people make. I find that it actually helps people when they call in to talk to somebody who has osteoporosis or has experience with osteoporosis. It makes them feel a lot better, and it makes me feel better too, that I'm doing something worthwhile, something that can help, even in just a very small way. People shouldn't think that because they've got this condition, it's the end of the world. You can take medication, you can take vitamins, you can do exercises, follow your doctor's advice, and don't worry too much about it. That's one thing I could recommend to people.
Now let's take a look at some nursing interventions we have for Lola. So some nursing interventions include evaluate the patient's functional ability and note for any mobility alterations,
assist patient with walking and encourage active and passive range of motion exercises,
educate patient and family on assisting patient with mobility,
encourage deep breathing and coughing exercises,
encourage increased fluid intake to 1,500 milliliters,
consults with physiotherapist or occupational therapist,
and emphasize the importance of adherence to medication regimen.
Now we have examples of weight-bearing exercises Lola can do at home as per the physician's orders.
Pop quiz question number 4.
The correct answer for number 5 is D, all of the above. So there are 2 methods of exercise that aid in building or maintaining healthy bones, and they include weight-bearing aerobic exercises and strength and resistance exercises. Weight-bearing aerobic exercises such as walking, stair climbing, jogging, and Tai Chi, when performed with increasing intensity and speed, are able to limit the reduction of bone mineral density, or BMD. However, in order for the weight-bearing exercises to be effective, they must reach a mechanical intensity useful to determine an important ground reaction force. Ground reaction force is the force exerted on the body by the ground or surface it is making contact with. Strength and resistance exercises are carried out with loading such as lifting weights or without such as swimming and cycling. For this type of exercise to be effective, a joint reaction force superior to common daily activity with sensitive muscle strengthening must be delivered. These exercises appear extremely site-specific, able to increase muscle mass and BMD only in the stimulated body regions. Overall, for Lola, it is important that the intensity and speed of her exercises be monitored, only performing activities that her body can tolerate. This is done to avoid side effects such as lightheadedness and avoid risk of fall.
We're first going to start with a squat. Stand with your feet shoulder-width apart, then bend 30 to 40 degrees at the hips, then shift them back as you bend your knees and lower yourself to a comfortable position. Repeat 10 times. Now we're going to have single leg standing with support. So stand with your feet shoulder-width apart, bend one knee slightly and slowly lift that leg off the floor. Hold for 10 seconds before dropping. And then repeat 10 times for each leg. Now this is called a sit to stand. So we stand with a chair behind us, bend at the knees and hips, and slowly lower yourself to a sitting position. Pause and stand up and repeat 10 times. Next is a forward lunge. So we stand shoulder-width apart, step forward with one foot and shift your weight onto that front foot. Return to standing position and repeat 10 times for each leg. Last, we have step-ups. Stand in front of a low step and place one foot on the step, pushing through the heel. Move up, then back down, and repeat 10 times for each leg. Pop quiz question number 5.
B. Increased consumption of foods such as dairy products, salmon, and vegetables. The following are all examples of calcium-rich foods. A diet high in calcium of at least 1,200 milligrams per day, which can include dairy products, baked beans, tofu, salmon, and vegetables, is recommended. Lola should also take doses from 500 to 600 milligrams to aid with adequate absorption. Calcium, as previously explained, plays a role in bone mineralization and formation, therefore preventing fragility. C. Spending more time outdoors, getting sun exposure. Spending more time outdoors for sun exposure promotes vitamin D levels. Dietary modifications can include vitamin D as well, aiming for the recommended minimum of 400 units or 800 to 2,000 units for elderly and chronic clients. Salmon, fortified dairy products, soy milk, orange juice, and cereal are all examples.
So now all of you may be wondering, how did Lola get through her osteoporosis? Is there a happy ending? Did her bones get any better, or did they get worse? Well, we're glad you asked. Lola and her grandson actually sent us a letter regarding the updates in her condition. She was so thankful to be a part of this documentary we made just for her. This is the letter she wrote, and it reads,
Dear osteoporosis team, it's been almost a year since my fall and I'm feeling so much better. I'm so glad I asked for a referral to one of Canada's most well-known osteoporosis specialist, Dr. Suss. Under his care, I was prescribed bisphosphonates and all those other drugs. And with much determination, I regained my health and I am no longer considered osteoporotic. However, I'm still within the range of osteopenia as my DEXA result says I have a 1.9. But isn't that great news that my bones are improving? Oh, I forgot to mention I finally stopped drinking alcohol with my bingo buddies and started drinking milk. Dr. Suss told me that low-fat milk has a higher calcium content by weight than whole milk, so I get so much of my daily value of calcium from that. Oh, and I also got a job from the Beekeeping Honey Incorporation this summer, and I'm starting to go outside and keep myself active by becoming a beekeeper again. Did I tell you I was a retired beekeeper before? I'm getting a lot of sun and always make sure to put on protection and my sun hat my grandson gifted me. I don't see as if osteoporosis has changed my life too much. I like to think I still live quite normally. However, I do take every precaution to avoid falls. I keep in mind that I have to be very careful coming down the stairs or on escalators. I always hold on to the handrail and I'm not shy about asking to hold someone's hand if necessary. I feel that being optimistic and thinking positively is important through my condition. Anyways, I can't wait to see the full documentary when it's released. Isn't the release date November 28th? I'll make sure to watch it with my grandson. Thank you, osteoporosis team. Well wishes, hugs and kisses. Lola.